It's my pleasure to present the result of the early TAVR trial investigating the role of TAVR for asymptomatic severe aortic stenosis. Here are my disclosures. For patients with asymptomatic severe aortic stenosis and preserved LVEF, current guidelines recommend clinical surveillance with routine follow-up every 6 to 12 months. Recently, 2 small randomized clinical trials evaluating younger patients with very severe aortic stenosis demonstrate a benefit for early surgical AVR compared to clinical surveillance. To date, no trial has explored a strategy of early TAVR compared to guideline-indicated clinical surveillance. The purpose of the early TAVR trial was to determine the safety and the effectiveness of a strategy of early intervention with TAVR compared to clinical surveillance in patients with asymptomatic severe AS. Early TAVR trial was a prospective multi-center randomized control trial evaluating patients with asymptomatic severe AS. Asymptomatic status was confirmed by a negative treadmill stress test. Randomization occurred 1-for-1 to either transfemoral TAVR using a SAPIEN 3 or a SAPIEN 3 Ultra valve, or to clinical surveillance. Primary endpoint was a composite of all-cause death, any stroke, or unplanned cardiovascular hospitalization at a minimum follow-up of 2 years. Early TAVR trial enrolled at 75 clinical sites, 72 in the United States and 3 in Canada. The key inclusion criteria include age 65 and above, severe aortic stenosis defined by standard criteria, LV ejection fraction 50% or above, asymptomatic status confirmed by negative treadmill stress test in the vast majority of patients, or if the patient could not do a stress test, by detailed clinical history alone. Patient had to have an STS score of 10 or less. Key exclusion criteria include any class 1 indication for TAVR or for AVR, unsuitable anatomy for TF TAVR using S3 or S3 Ultra balloon expandable valve. Of note, bicuspid were allowed in the trial if they had favorable anatomy for TF TAVR with a balloon S3 valve. The primary endpoint was a composite of all-cause mortality, any stroke, or unplanned cardiovascular hospitalization. The primary endpoint was tested for security in the intent-to-treat population after a minimum follow-up of 2 years. Unplanned cardiovascular hospitalization was defined as follows: any cardiovascular hospitalization through an ED department or admission for clinic therapy, intensification, or lasting more than 24 hours. And any aortic valve intervention or intervention that occurred within 6 months were considered also unplanned cardiovascular hospitalization. The second endpoint are listed below. The first one was a favorable health status outcome, defined as being alive at 2 years with a key CCQ score of 75 or greater that did not decrease more than 10 points from baseline. Integrated LV and LA health at 2 years, a marker of cardiac damage as defined below, a change in LVEF from baseline up to 2 years, new onset atrial fibrillation, or death or disabling stroke. Here's the patient flow. 1,578 patients were consented for screening between March 2017 and December 2021. 43% were excluded. Main reason because they already had a class 1 indication for AVR or they had anatomical exclusion. 901 patients were randomized 1-for-1 with 455 patients in transfemoral TAVR and 446 in a clinical surveillance group. Here's the patient follow-up. Patient had a minimum follow-up of 2 years and a median follow-up of 3.8 years. Up more than 97% of the patients were available for primary analysis. Here's the baseline characteristic. The mean age was around 76 years old. Female were present at 30% approximately. 84% of the patients were at low risk for the heart team. Treadmill stress test was performed in more than 90% of the patients. The key CCQ score was very high at 93, and bicuspid valve were present in around 9%. Baseline echo characteristics were similar between both groups, with aortic valve area around 0.9, peak velocity around 4.3, mean gradient around 46, and LVEF absolutely normal above 67%. In the early TAVR trial, the primary endpoint of death, stroke, and unplanned cardiovascular hospitalization was 51.2% in the clinical surveillance and 35.1% in the early TAVR group, corresponding Thank you. Corresponding at a 50% reduction of the primary endpoint with a number needed to treat of 6 to avoid 1 event at 2 years. Shown differently, the primary endpoint is composite, shown a number of patients with event that is proportion. The primary endpoint was 26.8% in the early TAVR group compared to 45.3%. All-cause death were similar between both groups. Stroke were numerically lower in the early TAVR group, and unplanned cardiovascularization was significantly reduced with the early TAVR group. Shown differently with Kaplan-Meier estimate, there's no difference in mortality. There's numerically decrease in stroke with early TAVR group, and a significantly reduction of unplanned cardiovascular hospitalization with the early TAVR group. The subgroup analysis of the primary endpoint demonstrate consistent benefit of early TAVR strategy for all pre-specified subgroup. Looking at the additional endpoint of death, stroke, or hospitalization for heart failure, actually severe hospitalization for heart failure, still show the superiority of early TAVR strategy compared to clinical surveillance. Pre-specified secondary endpoint also showed the superiority of early TAVR strategy compared to clinical surveillance in terms of favorable health status outcome and integrated LV-LA health at 2 years, with no difference in change in LVEF from baseline at 2 years. In terms of conversion to AVR for patients in the clinical surveillance group, median time to conversion was at 11 months. 26.2% of the patients convert at 6 months, about 50% convert at 1 year, and more than 70% convert at 2 years. In terms of symptom at time of conversion to AVR, the vast majority of patients converted with dyspnea at 83%, and up to 30% of the patients presented with severe heart failure class 3 and 4. In terms of clinical presentation at time of AVR conversion, we classify patients based on acuity and severity of the signs and symptoms at conversion. Patient either converted while being asymptomatic, while having progressive signs and symptoms, or with advanced sign or symptom or acute decompensation, such as New York Heart Association 304, syncope, ventricular arrhythmia, pulmonary edema with heart failure, or a drop of EF less than 50%. When looking at the sign and symptom at time of conversion to AVR, approximately 40% of patients through time presented with advanced and severe signs and symptoms. Approximately 60% present with progressive signs and symptoms. And a very small minority of patients, 2% approximately, presented with no symptom. We call this curve internally the rainbow curve. The proportion of patients presenting with advanced signs and symptoms was consistent through time, and also similar with the early converter between 0 to 6 months. We perform also an extra analysis of the primary endpoint, where instead of considering all intervention within 6 months and consider them as unplanned cardiovascular hospitalization, we consider all intervention associated with advanced signs and symptoms at any time point, which still demonstrated the superiority of early TAVR strategy compared to clinical surveillance. Very important to mention that the readiness and the promptness of treatment in early TAVR was exceptional. Looking at the median time from randomization to early TAVR treatment, it was a median of 14 days. When looking at the median time from AVR indication or conversion to symptoms, patients in the CS group received AVR at a median of 32 days, which is very, very efficient and quick. About 90% of clinical surveillance patients were converted to AVR, were treated within 3 months of indication for AVR. 30-day peripostural outcome were also excellent after TAVR in both groups. CV death in both groups was 0%. Stroke was very low in both groups, and new permanent pacemaker also exceptionally low. Obviously, our trial has some limitation we should acknowledge. The result should apply only to the trial population, which included patients of 65 years old or greater who were suitable for TF-TAVR. Findings may not be applicable to other TAVR platforms. Less rigorous clinical surveillance and absence of early TAVR planning may result in different outcomes, and the trial was conducted during COVID-19, which may have affected outcome. In conclusion, in patients with asymptomatic severe AS, a strategy of early TAVR compared with clinical surveillance resulted in a significant reduction of the primary endpoint of death, stroke, and unplanned cardiovascular hospitalization. Multiple endpoint variations demonstrated consistent result. Early TAVR was not associated with excess mortality or stroke. Early TAVR prevented a clinically meaningful decline in quality of life in clinical surveillance patients who subsequently converted to an AVR. And a strategy of early TAVR improved measure of LV and LA function, a marker of cardiac damage. As far as clinical implications, given the benefits observed and the lack of harm, early TAVR may be preferred to clinical surveillance in patients with asymptomatic severe AS, especially when combined with the challenges of a timely symptom recognition and prompt treatment in a real-world setting.